Welcome to another edition of Turning Points TV. I am Margie Dawson, the Development Director here at Turning Points. Everyone knows about the different services that Turning Points does in the community, but today we are going to focus on the great medical services that are done here every day. So don't go away, we'll be right back with another edition of Turning Points TV. Here we are now with Adele Eroser, the Executive Director of Turning Points. And she's going to tell us a little about the one-stop medical clinic here at Turning Points.
Well, I'd just like you to know, Margie, that we started in 2009, and we were able to start because of a partnership with Lake Erie College of Medicine, LECOM. And without their help, we never would have been able to get this clinic off the ground. So we've been able to use fourth-year medical students who provide the primary care for our clients, and they're supervised by volunteer physicians and also recently by our medical director that we were able to hire just in this last year. So the clinic has had several years to start up and get going. We've gone through several phases. We had Manatee Memorial Hospital residents. At one point, we went from 2 exam rooms to 8 exam rooms now. So we've had quite an expansion, and that was primarily because of the huge need that we have seen, and it's certainly grown in the last few years.
And what is this need in Manatee County?
Well, we have a lot of people who are uninsured and underinsured or have no income. And so our target population is those people who are uninsured. And we serve a lot of people, not just with primary care now, but because the need for specialty services also came along as after they've seen the primary care physician and they determine what their needs are, they need to be able to refer them to a specialist. And that was a roadblock in the beginning because we didn't have any specialty services here. But as you'll hear later from Dr. Cirillo, our new medical director, that we've been able to grow that specialty care primarily because of the generosity of a lot of physicians here in our community. They're very good about giving back and being able to provide that specialty care that really closes the loop on what these people need. But we've seen such a growth in the number of people that are coming in. A lot of, as you know, the state of Florida did not take Medicaid funding expansion, so that leaves a lot of people who are still not covered, and they have to have an option to be able to go and get seen. We're trying to take the pressure off of the emergency rooms in the hospital for people who just have things that are primary care needs, and that's our major focus.
So what makes the One Stop Center so unique?
Well, when we started way back in 2004, 2005, trying to decide what we were going to do to address the need in the community, we looked at a lot of different best practices throughout the whole United States, and we found that what the major difference was in a one-stop center is they're able to provide a lot of services in one place, in one site, so that people don't have to have a barrier of transportation. They aren't sent from place to place to place with being frustrated with not getting the help that they need because all the services they need are in one place. Or if you're not able to handle it here, and this is what we do, is we are able to handle referrals directly to partners that we know will be able to help these people. So it's integrative care. It's integrating not only food, clothing, rent and utility assistance, but some of those other things that contribute to homelessness, like medical and dental. When we built this building, we surveyed clients to see what their needs were, and many of them were homeless because they had had a medical incident in their past, they weren't able to work anymore, and then that led to a series of spirals downward where they were not able to get any kind of help. So this is the kind of thing that we were trying to help with, is with our clinic establishing the medical and dental free clinic so that people are able to come in and have access to primary care and dental care. This has now been adopted throughout the country as a best practice because you're integrating a lot of their physical needs along with their medical needs. So we also have services here that we adopted, not just the medical services and dental, but we worked again with Lake Erie College of Medicine pharmacy students. And the pharmacy students really are an important part of the foundation of the medical program. They work directly with the physicians to make sure that clients get the prescriptions that they need. Many of them can't afford to pay for their prescriptions, so the pharmacy students help them into prescription assistance programs which provide their medications for free. They counsel and educate them about how to take their medicines. They follow up with them, make sure that they're taking them correctly. They follow up with any side effects, making sure they're better educated than we are usually about how to take and what to watch for with their medications. And that's been really, again, one of the unique things is you have a dentist, you have a doctor, sometimes a specialty doctor, and a pharmacist all discussing your case. So it's really integrating all of those different specialties into the care that we provide here.
And there is nothing else like this in Manatee County, correct?
No, we don't. There's no other medical site like this. There are other places that serve people who are uninsured, but there's no site like this that takes care of everything, like from needing a shower to needing help with rent and utilities to needing your tooth pulled. So those are all things that we provide here.
And now we are with Dr. Ron Cirillo. He is the medical director here at Turning Points. So, Dr. Cirillo,
Yes, ma'am.
tell us about your medical background and what brought you here to Turning Points.
Well, I come from training in internal medicine, gastroenterology, and hepatology. I was in private practice for over 30 years in Stamford, Connecticut. Before that, I was trained in New York, New Jersey, and Philadelphia. The experience I had was in private practice and a major teaching affiliate at Columbia University in New York. After that, I retired for about 6 months and then determined that that wasn't what I was going to do. I worked for the VA for a couple of years, and that was an experience that sometime we could talk about. But after that, I was offered the job as medical director here. And it was an interesting situation because originally we talked about starting a hepatitis C. I am a gastroenterologist, hepatologist, and liver diseases was my specialty. Hepatitis C was, too many people we found across the country had hepatitis C, and we couldn't explain the roots of hepatitis C. Many of them were not using drugs or had no experience with transfusions, and we looked for other methods that this could be communicated. Well, that was exciting here at the center. And I said, by the way, we can use a medical director. How about you doing your hepatitis C and looking over the medical program? Well, I found a unique experience here. First of all, the educational experience was none that I know of. I was trained in internal medicine, and those programs were very strict and very traditional. Inner city always, both in New York, New Jersey, and Camden, New Jersey, as a matter of fact, outside of Newark, and then in Brooklyn, New York, and after that was private practice.
So tell us a little bit more about your background and experiences and what brought you here to Turning Points.
Well, as I said, my experience has been internal medicine, gastroenterology, hepatology. It's been in private practice. However, we were a major teaching affiliate at Columbia University and enjoyed working with residents and students. So when the opportunity here came up, not only to run the hepatitis C program, but to work with the residents and students, I value that and wanted to continue with that. The program here is so unique. I've never been in an experience like this. We have fourth-year students from LECOM. We have Blake Medical residents, first and second year. We also have pharmacology students and a PharmD present at all time. And the integration, as you can see, which goes on here between the pharmacy, the students, and the residents, nowhere else have had experience where we could turn to a pharmacist and say, hey, look, we have this population, we know what we should prescribe, but what can we afford? What do we have available here? What can we offer our patients? And the unique response between the interplay between the pharmacists and the physicians is something we never had in our training. That led us to another area of working out programs with Pharm. Here at Turning Point, we not only have pharmacists helping us decide on the best medicine, the most effective medicine, and the cheapest medicine, but certain programs that they manage themselves. It's so easy when we have a diabetic say, okay, we're going to manage the medical problem, but the actual drugs and amount and what we could use and how we can change things, the PharmD program has their own management of patients, both for diabetes, for COPD, even our sleep apnea patients with certain medicines we work on. It's amazing, and they're followed with a smoking cessation program, with a drug rehabilitation idea, because many of our patients are either smokers or used to drugs, abuse drugs. So that influence with the PharmD, with an ongoing program, can not only follow our patients that are medically treated, but with pharmacological adjusting their dosage and all, it's amazing. And the residents and students, fourth year, they see the patients, they're deciding what has to be done. We have 16 subspecialists here, all on a volunteer basis. And the students, pharmacists, and the residents have a one-on-one relationship with the attending of the day. They'll see the patients together, they'll discuss differential diagnosis, they'll talk about alternative treatments, be that medicines that maybe we wouldn't use in private practice, but affordability is a key here. None of us came from a training where we were actually economically structured towards a particular drug or not, or a particular treatment program. Here we are. And that's amazing to have at the fingertips. And what really gets me too is the relationship established between the pharmacist and doctors. You don't see that outside. Many of the residents that come through here, I insist that they meet the pharmacist in their hospital, get to know them personally, professionally, and use them as a resource. Unfortunately, today, most of us in private practice are the only kind of pharmacological background we see of through drug reps, and they are tainted. Very often what they present is not incorrect information, but it's information about their particular drug. To have an outlet, someone you can call in a hospital or as a private attending in a community. And I insist on the Pharm students, too, that they get to meet their docs in the local community and discuss how they could treat their patients, what they could use maybe instead of, or if there's a drug interaction that's relatively new, to discuss that with one another. And I think that's an important relationship for the Pharm students that are graduating, and in another couple of months will be out in all your local pharmacists, and our students, which will be residents in a couple of months, and for them to establish this relationship between Pharm and internal medicine or their subspecialist. The uniqueness here with the students is they have an opportunity to do their general medical rotation, and then in the afternoons we have subspecialty clinics, and they could rotate through ophthalmology, gynecology, gastroenterology, hepatology, goes down the line, and they could decide, well, what do they want to concentrate on when they finish their residency, when they finish or just enter their residency, what they want to concentrate on in subspecialties, if that's for them. Very important to see the people we have here are so qualified. Most of them are retired or giving time back in the latter part of their practices, and they have so much to offer. I don't see you'll see these kind of professors on the floors in the hospital, because most of them have the free time and the availability to spend time with the patients and the students. If it takes us an hour with a particular patient here, because many of these patients are indigent, we would call them street people in inner city, but here we like to call them palm people. They're either migrant workers, they're fishermen from the Cortez village that no longer fish or have lost their boats and need medical care. So they have to be real. Everyone who comes in here gets a complete history and physical. We go over everything. They may be coming in for a suture wound or particular infection, but we'll go over their complete medical history because we know there's no one else treating these patients. One of the big things I see here in Florida in itself, there aren't many clinics associated with the hospitals, that the patients either use the ER as their clinic or don't get treated. But here, it's a halfway house. I think the admissions, or not even admissions, but the entrance numbers of people who go to the ER have been greatly reduced because we're here. We're here to manage everyday current medicines. We're here to do an EKG and to do blood work on the spot. Whereas I think in the past people would use the emergency room, and that would take up so much time in the emergency room, overload. Emergency room is not a clinic. We are a clinic here. We're more of an outpatient area where a patient can see their own doctor. The rotations here are set, so they'll see the same doctor. The continuity of care is great. And the main thing here, the educational process, is knowing when a patient needs to be in the emergency room. That's so valuable. Say, hey, look, we can't treat this here. This patient needs emergent care. So one of the continuity things we have going, if we send a patient to the emergency room for here, we call the emergency room. We tell them what we have, what we've done, what we think. Then the next day, the resident or student will call the hospital, see what the management of the patient was, what we may have missed or the hospital may have missed, and discuss the case and see where we go from there. Also, we establishing now a relationship. Most of our patients go to Manatee Hospital. We have a direct line with them. And after speaking to the director of the Manatee program, we're going to have a direct line to get communication immediately after that patient's been either treated and released, seen and admitted for a few days, and then released, because the follow-up will be on us, taking the burden off the hospital and also providing a setting where the patient is comfortable. It's near their local living quarters, whatever they may be, but they know they can come back here for any particular problem. When I started here, it was basically a volunteer program, which it still is, and we desperately need volunteers in all area medicine. So if any physicians are interested, please contact me. And people will work a couple hours a month, a couple hours a week, or like many of them, a lot of hours a week. This is to provide care and instruction for the students and residents that rotate through here. I think our attendings now, we've gotten such an influx of subspecialists that it's giving not only a general medical experience to the students and residents, but also the subspecialties. And I think the attendings here rotate. They have a good time with the students. I think it's a learning experience that they won't quite see anywhere else. And our fourth-year students in a few months are going to be out there in the hospitals, and our residents are going to be practicing medicine. Hopefully this experience will show them what an indigent population is, how care is given without all the availabilities of the thing they have in the ER, the stat bloods, the stat x-rays. Here it's more physical diagnosis. If you can't determine a particular problem that you need an x-ray for, well, that's different. But here, to not rely on tests so much, to not rely on the x-ray being in your hand, but figuring out what's going on, how to manage and stabilize the patient to get them to where they can get more help. But the programs here, like the hepatitis C, going back to, this community is inundated. We have a large drug population, and they're inundated with hepatitis C, and it's a disease you may not even know you have. It's something found in the blood. You're usually not sick from it until it's too late, and many of them are carriers and go out in the community and share that hepatitis C. We have a means and direction. We have a grant to do finger stick testing here. In 20 minutes, we could know if you have hepatitis C or not and begin treatment. It's very expensive treatment for hepatitis C, but it's 96 to 98% effective. So we can offer a cure to this community. A lot of things and a lot of studies we're looking at on this population too. Maybe this could be the answer where hepatitis C is coming from. Most of our patients here, if they do work, They're working in cleaning jobs, in household jobs, in restaurants, in fish supply business, picking fruit. Maybe there's another transmission process. And I think communities across the country, if they could look at the heavy Hep C population in an indigent population, we may be able to eradicate hepatitis C. And that's one of my primary goals. But I've been so involved with the teaching program and being a preceptor for the students rotating through that it's taken a little time away from that. But we're hoping for better grants so that we can go out and get these patients. We just now started our Narcan in the field program, and we have here at the center at Turning Points, we have a VA program for the homeless and VA patients. We have dental programs, but the VA and a lot of our outreach programs go out into the community. So hopefully, under our direction in the medical department, that the Narcan will be distributed to these group populations. So we won't see as many overdoses and deaths due to overdose, or fill up the emergency rooms again, where we could treat a problem, identify a patient, and at least save lives. Most of the patients, very interestingly, that come here don't know the services we provide. They come to see a doctor and they have something, and they don't know about our programs of smoking cessation. They don't know about our programs of managing their diabetes. Many of them can't or don't have the ability to understand how to take their blood glucose levels at certain times during the day. Here they could learn that. They come in a program and it's actually done with them and for them. Their medicines are adjusted through the pharmacist and medical team. That needs to be managed. Many of the hygiene areas here are poor, and diabetic ulcers are not treated and have to be treated. And it's a matter of treating the particular infection, but also managing that diabetes so they don't get to another problem with their infection. Again, a lot of hypertension patients that don't know they have hypertension, just have a headache or feel something different, and they come in and be evaluated. We'll do EKGs, we'll send alpha bloods, but many of the things here we could treat rapidly. Hopefully in the future we're going to start a fast track or a treat and release program where they'll come in again with more physicians signing up and available hours. Even nurses that we need to vet and screen these patients before we see them will be able to have a walk-in clinic where we could utilize our time to the maximum extent. And, you know, sometimes here we have on any given day 5 medical students, 3 residents, and probably 40,000 pharmacists that come here and will be available to take and treat and help a patient.
Now, you mentioned some of the subspecialties. What are they?
Well, funny you should mention that. We have approximately 16 subspecialties that we have clinics here. And I'll just mention them so we could talk a little about them. We have cardiology, gastroenterology, hepatology, pulmonology, intensive care medicine, ophthalmology, OBGYN, surgery, ER, neurology, podiatry, dermatology, audiology, ENT, family practice, and of course our PharmD program and specialist. But interestingly enough, we just instituted the ophthalmology program where we have slit lamp examinations, we have the equipment, we have equipment for photography, retinal photography, very important in diabetics and management glaucoma. In the other areas, as I said, in the morning it's usually general medical. In the afternoons, we try to specialize with subspecialists coming in. So they'll follow up. We'll refer within our own clinic. For example, if we see a patient and a patient has a cardiac problem and we're treating it, we'll say, we want you to see our cardiologist for follow-up, and he's here on Monday. Make an appointment Monday, and we schedule a patient to make an appointment for Monday, so they also get the subspecialty care. These indigent patients are not only getting treat and release or general medical care, but they're getting subspecialist care, follow-up, even if it's to renew their medicines or reevaluate their medicines, which the ER doesn't have time, nor can they find private physicians that they can get in to see to have that done. So it's really important here, all the way from podiatry and foot injuries and treating foot problems. it's all available to the patient. They'll be screened general medical first, full history and physical, and then sent to the subspecialist. So there's no need to go anywhere else once you're admitted into the center. Once you're one of our patients, it will be followed by the subspecialist. I don't think any other clinics have that array of subspecialty that we have available here. And another thing is the Hep C clinic. Many of the patients we're screening in general medicine for Hep C. It is recommended risk factors for Hep C is just birth date. Anyone born between 1945 and 65. Tattoos, body piercing, incarceration, exposure to other people's with Hep C, multiple sexual partners, anywhere that Hep C could have been transmitted is a guideline to have that testing. So we welcome people in the community if they're able to be our patients here, and that's by requirements of, we accept indigent patients. That means patients without insurance, no Medicare, Medicaid, any of those. They get services. We are purely for the people that have that are 250% below the poverty level. So it's really the street people we're talking about that have no access to medical care, and that's why we're here. They never get to see a program, even if there's waiting lists for other programs, they really don't have availability that they have here. And we welcome all these people that may have been exposed to Hep C or don't even know they have Hep C, certainly if they're born between that period, to come into the clinic. Unfortunately, it doesn't get publicized to these people, but if they come in for a general medical exam and are worked up, that'll be picked up, and they'll get that hepatitis C probably the same day they come in. And it's just a matter of waiting a 20-minute period, and we'll know the results. So we welcome all the patients in the community to see if they're meet the criteria to become our patients here. We're happy to institute them into a regular program, which I think will provide most of their basic medical care for their lives. We find, we work with volunteers. We need volunteers desperately in all areas of medicine, even volunteers in the business world. We have a business center where they help patients work on the computer and make applications out if they're looking for jobs. We have the VA program, as I mentioned. We feed our community here with our kitchen and clothing and laundry. All of those things, if they're coming in for those services, if they're using them, come over to the medical clinic, register, be put in an appointment to have your medical. Even if they're on medicines and they're just about to run out, come in. We'll review that and see if those are the medicines they should be on. But we're available to all the patients in Manatee County that fit our requirements. Even a phone call from patients to say, hey, I live in Manatee County, this is it, I have no source of income, can I get medical care? And they will be given all that information. But volunteers, we need in every aspect. Even for secretarial work, anybody that has a few hours to give, that's what we function on. And of course, grants and donations, but volunteers make this place run.
Now, you're very passionate about medicine and about the work being done here. How important is it for our community and also for the students and the residents that are here?
Well, for the community, it's a must. We are here to provide a basic medical need. These patients need it. They're here, and it's available to them at this moment. Depending on funding and things like that, we can't predict the future. Right now, we're here, up and running. The more patients we have, the more active this is, the better treatment these patients will get. The educational part of it, I can't say enough about. The students, the residents, personally, and I went through major programs that I thought were excellent, did not have the availability to see your own patients' fourth and first and second year residencies, to manage and treat, to have a one-on-one experience with an attending who's done it for 35 or more years, who comes from teaching programs all over the country. We're not just South. We have people from all over, and it's amazing how we can communicate here for the general population. It's been a shift for me, being with inner city patients coming into the what can I say, the palm people again, relating to that population is so different, but yet the sicknesses, the diseases, the problems are the same. And it's not a predominant ethnic group. It's a mixture of many, many people from all over the South, farm workers, fishermen. Is no particular one area that these people come from. They're people that at current time in their lives need medical help, and that's what we're here to provide, and it's free medical help. And I think they'll be treated with respect here. We don't question their lifestyle or why they are where they are, but we're offering medical help, and we take all comers here, especially a lot of our migrant. We're right near, Orange Country and Tropicana, and these kind of programs. Many migrant farm workers can't do it anymore. Where do they go? Where do they get help? And it's here. And many of them are in an age group that we could treat that are not, if you think about it, most people over 65 will get some sort of assistance, whether it's Medicare or not. Medicaid comes in play, but what about the ones that fall through the cracks, that are 62 years old and have a medical problem? We all know that's the majority of the patients that can be treated and should be started on treatment. 40s, 50s, people interested in getting off their drug habit. It's amazing with the Hep C program, we require here a drug-free environment, meaning no drugs, for a month before any treatments began. And we found, looking back at our numbers, that many of these people, they were so motivated to have hepatitis C treated and cured, stay off their drugs. They're committed. Of course, they're coming here for a commitment to make a healthy life for themselves and find that, hey, I've gotten rid of Hep C. Why should I go back to drugs? Why should I expose myself again? And the treatment is 1 pill a day for 12 weeks, and that's for cure. So this is important to get out to the community. And how we do that is through programs like this to get, mostly for the patients, to come out, to call the number here at Turning Points and let them know that you're interested in medical care, and have them direct you to where it may not even be medical care. It may be a job, or I have an application for a job. How can I get this taken care of? Who could help me with it? We have people ready and willing on computers to help the patients with that, to help the community with that. You'll find every morning that we have a gathering of pretty much regulars that come out in front of the center and will have their meal, or maybe talk to each other in our rec area, and at least communicate. Drop by the medical part. It's the door on the right, all the way on the right, and just say, look, I'd like to sign up and have my medical health evaluated. And I think that's where the experience comes in.
And then what are your final thoughts?
Final thoughts, a lot. We exist solely on volunteers, as I said. We're nothing without our docs, and so many have given so much time. Volunteers at any end of the spectrum, medically or not, we need funding. We are on a year-to-year basis. I've been here only a year and a half, and it started out with a few docs giving some of their time and a couple of students, and now it's a full-fledged program with 16 or so subspecialties. I think getting the word out to people, and that takes money to run the center, to pay for the electricity, those kind of things. The grants we're constantly working on. We got all the Hep C testing and all through grants. We have Harvoni treatment through Harvoni's generosity, but we can't do it on our own. And funding's a big thing. Even this year, we don't know where our funds are coming from. But Manatee County is unique. There's a cross-section of people that desperately, it's a poor community. It's a community that needs medical care, and it's not available. Unfortunately, our hospitals don't have walk-in clinics. This is what we'd like to see. And then we could be a purely outpatient managed medicine after they're finished with them. But right now, we're a full service. Do what we can and try to cut down those numbers for our local community hospitals that are funded also. Hi, I'm Dr. Ronald Cirillo. I am Medical Director of Turning Points Clinic. We're here in our examining room, which is an ophthalmology room, looking at equipment that has been donated to the center here. We do slit lamp examinations and photography of retinal areas seen in diabetics, and management of the diabetic is through ophthalmology plus all sorts of general medical care. I have with me one of the fourth-year LECOM medical students, Nick Ross, and I'm going to ask him a few questions about the educational process here at Turning Points. Not only is this important for other people wanting to do rotations through Turning Point, but for our community that desperately needs all these professionals here during the day. So, Nick.
Yes, sir.
Tell us a little about your training here at Turning Points.
It's been the most multifactorial training I've ever come across. I've been working with multiple specialists, from you doing the GI, cardiologist, pulmonologist, and it's been very comprehensive. Also, even though it's a free clinic, it's been a very amazing experience.
The population that's here, what we say is indigent population, but our street population here. How have you found that experience in working with this type of?
It's actually been very motivating. Because we're helping out so much. I'm glad that we get a lot of the donations, and that doctors like you are giving your time. It's inspiring, to say the least. These people need care. They sometimes come from foreign countries, medical care for sometimes decades long of not anybody touching anything, from chronic conditions like diabetes or hypothyroidism, or even sometimes where they're just experiencing something minor like low back pain, and we're the ones on the front line helping. So, as I said, it's been extremely inspiring, and it's nice.
And well, thank you for that, but I find it rewarding too, training in inner cities with indigent population. It's so different here in the South, and obviously you're from the South, kind of. But the population here is I try to tell the residents and the students, they do training, do it in inner cities, do it in communities that see tremendous overload of patients, because that's the way you learn. But here in Bradenton, in Manatee County, the indigent population is every bit as large as it is in inner cities. They may be spread out a little more, but they're here, and that kind of training is important. What do you envision to do with the experience you have here?
In the short term, I do want to do the same thing that is helping with a population, whether my residency does include a free clinic or not. Further out, when I actually do become board certified, I do want to have some time within a hospital that has an underserved population, whether it's rural, whether it's even within an inner city. Either one is fine. And then actually in long term, if way long term, roughly partial retirement, I would like to do the same thing. Volunteer within a free clinic, assist some way that would be for an indigent or impoverished population.
What can you say to students in LECOM, and we have Blake residents too, about volunteering here, about doing their rotations here? Would it be something you would recommend for them to do?
Yeah, highly recommend. I actually had no known underserved experience. I did not know what it was like to work with people who did not have health insurance or have been in an impoverished setting prior to this. We've been very much dealing with, I guess you could say, kind of a tailored medicine prior to this experience, so I would highly recommend it.
Well, thank you. I'd like to, again, reiterate that. So it's so important to have your fellow students rotate through here. They have options to do other clinics, and this clinic being totally underserved population and an indigent population, that maybe we can encourage them by seeing this and by talking to you to have them volunteer. Even first and second year, there are many positions here we need filled. Even this room and the equipment it has, a technician can be trained out of one of the students to do our photography. It's not being occupied at this particular time because we don't have the trainees to do that. So if there are LECOM students or medical students or anyone out there that's looking to spend time, RNs, and may have extra time, this is a place that would value your volunteer time. Hi, I'm here with Zane Scott, who's a fourth-year LECOM student who's rotated now for how long, Zane?
This is my second rotation, right in the middle now. So.
And how long is that?
About 6 weeks total.
Okay, and you're on a 2-month rotation, then that'll be great. Could you tell us a little about your experience here? You're a fourth-year student, you're months away from being in a residency program. How has this prepared you? What's different about this program? What can you say? And negative, positive, I'd like to know.
I've definitely enjoyed this rotation. It's been really cool because we'll get to kind of think about different patients and what we would want to do, and then run it past the doctor and see if that is kind of what we should do or not, and then kind of tweak our plan and kind of figure out what the best thing to do from there. I really liked everything so far. Everyone's been really nice. Patients are great. It's been a great experience. It really has.
Do you feel a setting like this is a learning experience that is expected, is beyond expectations, is something that you may have taken away something that you may not have from another program?
Oh, definitely. I didn't realize it was going to be this great, actually. I just feel like I've gotten to do a lot more than I kind of anticipated. But yeah, it's been really great. Definitely exceeded expectations, I would say.
Well, thank you. Would you recommend this rotation to other LECOM students, be it first, second, third, fourth year? You know, we desperately need volunteers. We're out there trying to get volunteers. This rotation, I know you have many others to choose from. Could you tell me maybe how you would approach those or speak to the students and residents that may want to volunteer?
Oh, definitely. Yeah, I've enjoyed it here so much. I would recommend it to all my friends, and I would just everyone I've talked to said that who's been here before has liked it. I leave every day having a great time, happy to be here. So yeah, definitely.
Well, thank you. I think it's important that the residents and students that rotate through, and we do have residents here too, that the team approach of student, resident, pharmacy is paramount. I don't think many other programs have that, but I'd like to invite anybody who's interested from LECOM or any other rotations that are necessary in Blake Hospital. They want to come down and see the place. Other physicians, if they're available to spend some of the time, get to work with great people like Zane. Thank you. Thank you for seeing that program about Turning Points. Hopefully that gave you a little idea of what we do here and the services we provide. But this all exists because of volunteers. We're in desperate need of volunteers, be it nurse practitioners, nursing students, technicians, LPNs, anybody who's given health care, and especially physicians. If you're retired, you're out there, want to give some time, perhaps a lecture, an afternoon didactic lecture, working with a resident, working with a student, or just rotating through our clinic to give some of your time, it's desperately needed. Now is the time. I know, such as myself, a lot of retired docs are out there and looking to give back a little bit. We service a lot of hurricane victims that have moved here for years because of hurricanes up in the Panhandle. We have a unique community and in desperate need of your time. Please, if there's any interest at all, my name is Ronald Cirillo. I am a medical director of Turning Points. I'd be happy to talk to you. Anyone here in the office can give you information about volunteering, but this only exists with your help, and we're asking for that now. Please give us a call. Let us know if you have any kind of time available. We'd love to have you here and be part of our family.
Well, that about wraps it up with this edition of Turning Points TV. I hope you found out a lot of great information about the services that we do here at the Turning Points One Stop Clinic. And if you are interested in finding out more, call us or go online to our website. So thank you for joining us, and we'll see you next time on Turning Points TV.